I'm Ruth O'Regan. I'm a professor of medicine and division chief for hematology and medical oncology at the University of Wisconsin. Yeah, so tamoxifen and aromatase inhibitors are examples of what are called endocrine therapies. Sometimes they're called anti-estrogens, for example. They have somewhat similar, but also quite different mechanisms of action. So to start first with the aromatase inhibitors, there's three of these drugs, anastrozole, letrozole, and exemestane. And all three of these drugs work to reduce estrogen levels in postmenopausal females. So once women go through menopause, they make estrogen in their adrenal glands, in their adipose tissue, in their muscle. And the estrogen is made by converting androgens to estrogens using the enzyme aromatase. So the aromatase inhibitors inhibit the aromatase enzyme, thereby dropping estrogen levels down to undetectable. Um, and that's essentially how they work. So yeah, if you think about it, if these estrogen receptor positive cells require estrogen to grow, basically the estrogen levels are so low that there's nothing for them to grow from, if that makes sense. Side effect wise, most of the side effects are due to this low estrogen state. So we do have to check patients' bone densities because they can get loss of bone on these medications. But interesting, the most common side effect is joint pain, which we really don't know why patients get it, but it can be pretty significant. The other word of caution is that you can't use aromatase inhibitors in premenopausal patients because what happens is, what we think happens is that you initially get a little bit of a drop in estrogen, but then you get this feedback to the pituitary gland, which starts basically increasing the level of other hormones that stimulate the ovary. So you don't drop down your estrogen levels to any major degree in premenopausal patients. Now, tamoxifen is called a selective estrogen receptor modulator. And what it does is it binds the estrogen receptor on the cancer cells, but it results in incomplete dimerization of the receptors. So in order for the estrogen receptor to be active, it has to dimerize with another estrogen receptor. So tamoxifen kind of inhibits that process. But basically, if you like, locking the estrogen receptor. So again, no estrogen can get to these cancer cells. The selective estrogen receptor modulation part of it is the fact that tamoxifen, though it's an anti-estrogen on the breast and the central nervous system, it actually mimics the effects of estrogen in other parts of the body. So some of this is good. So unlike the aromatase inhibitors, tamoxifen can actually maintain or maybe even increase bone density. But some of these things are bad because one of the more serious issues with tamoxifen is an increased risk in uterine cancer, presumably due to its estrogen-like effects on the uterus. Now, this is something that we don't want to see in our patients, but in general, tamoxifen, if you like, associated uterine cancers tend to be very early stage and low grade, and they tend to be pretty easy to treat, but we don't want to see that. Also, because of its estrogen-like effects, it can also cause an increased risk of thromboembolic disease in patients. And in patients that are older, over the age of 70, there is an increased risk of strokes as well. So I would say overall, in general, for postmenopausal women, we use aromatase inhibitors, but it's not uncommon, actually, that patients can't tolerate those drugs very well. And then in that case, I would certainly go back to tamoxifen because the most important thing is that they're taking, one of the endocrine therapies. And interesting, if you look at tamoxifen versus the aromatase inhibitors head to head, it's a fairly modest difference in terms of efficacy. And one of the larger trials actually didn't show a survival advantage for using the aromatase inhibitors over tamoxifen. So they kind of have the same net effect on the estrogen receptor positive cancer cells. They just do it in a slightly different way.